prevention, early diagnosis and management.
Okay, this talk is going to be on H1N1 and its effects in pregnancy. I'll be talking about the prevention aspect, the management and the vaccination in brief. I'd like to keep it very short and simple because I know it's a very long day for all of you. So what is H1N1? We all know it's a very bad respiratory infection. It is just another strain of the normal influenza that keeps coming year after year. Okay, so it is a combination of the human, avian and swine flu. It's a very deadly lethal concoction of all the three viruses. The first epidemic started in June 2009. So that was detected in the Mayo Clinic, and since then it has become a problem every year, particularly during the winter seasons. So 9 years ago, sorry, the first one is supposed to be 9. 9 years ago, on the 18th of March 2009, that was the first index case that was detected in Mexico. And it didn't take long for it to spread to India. By 13th May 2009, it came to India. So this is the burden of H1N1 year after year from the year 2009 up until 2015. So we can see majority of the deaths or the cases happened in 2000, the first one was 2009 when 27,000 patients were diagnosed. And as it goes, there is a seasonal fluctuation, there is a variation that is seen with every year passing by. 2015 was considered as the worst phase in H1N1 infections, and Rajasthan probably was the worst affected. So India reported quite a big number of deaths in this particular year. So if you break it up, so that is how it looks like. The cases reported 2,569. The number one state was Rajasthan, and the number of deaths was probably highest in Maharashtra, unfortunately. 442 cases, 165 deaths. So what happened in 2017, that is last year, majority of the cases were reported from Tamil Nadu, followed by Maharashtra, and then the third state was Karnataka. So that is the breakup last year also. In Gujarat, they have also found out whether there is any correlation with those having comorbid conditions, and these are all the things. Pregnant women rank number 3 in this. So what is H1N1 virus? That is how a virus typically looks if you break it down. So H1N1 virus belongs to an orthomyxoviridae classification where there are 3 subtypes, A, B and C. A subtype is based on the expression of these 2 viral antigens. Basically, it's hemagglutinin and neuraminidase. So that is where the H and the N comes, H1N1. So hemagglutinin attaches the virus to the particular cell within the body. There are 16 variants in these. Neuraminidase is the thing wherein the virus gets released in the circulation. So there are 9 variants. So it could be H1 to H16, N1 to N9. So all these permutations and combinations can give rise to different strains and different mutations of this virus. Thankfully, B and C do not have any more subtypes. And type C is the one which causes very mild respiratory illness. So probably this is the one that we commonly see year after year, wherein they come, the flu starts off, they suffer for some time and then they go off. Was this only in 2009? Not really, because it started off in 1918. That is when the detection started off. So the first one that came was Spanish flu, which recorded 100 million deaths. That was in 1918. So as we go by, the last one that we see now is 2009, so the Mexican strain. So how does this get transmitted? Pigs are the most predominant vectors for transmission. They excrete these viruses and within 24 hours of their own infection. So pig-to-pig contact is common, and nose-to-nose contact, and the virus is shed in nasal secretions, and very commonly it gets transmitted by fomites, droplets or aerosols, which makes it very more virulent than the other ones. How does this differ from the normal seasonal flu? If it's a normal seasonal flu, patients usually have fever, cough, sore throat, body ache, etc. But swine flu typically has fever which is more than 102 degrees, 103 degrees, and lasts for a longer period of time. And intense excruciating pain or myalgia is a very common scene that is seen. So advice for the patients, if it's a seasonal flu, we usually advise them to take rest. But if it's for H1N1, the bed rest is for longer period of time. They need to wear a mask, they need to keep themselves protected and protect the others. Mortality in swine flu is reported on a rough scale of 1 in a lakh, whereas this swine flu is 1 in 10 lakhs. So as I mentioned earlier, it is a very good cocktail of all the 3 put together. And how do patients present? These are the common symptoms which is seen. Fever, as I said, intense fever 102, 103 degrees, cough, chills, headache, sore throat, stuffy nose, diarrhea, vomiting. These are very non-specific or atypical symptoms of H1N1. So somebody coming with diarrhea and vomiting usually get worked up for acute gastroenteritis, but it could be a different scenario altogether. If you break it system-wise, this is how we can simplify these things. Fever, lethargy, lack of appetite, running nose, sore throat, etc. How do we investigate these patients and how do we know that the patient has got swine flu? Simple things, we'll keep it simple. We'll give you a complete blood count, liver function test, a renal function test and a coagulation profile. On a complete blood count, we usually see neutropenia or a leukopenia. Liver function test, we can see a lot of liver function abnormalities where the enzymes get elevated. Kidney function test, because of severe dehydration, we can also see an elevation of the urea and creatinine. Coagulation abnormalities start off when the liver functions get predominantly altered. X-ray test and CT scan findings are very, very characteristics of H1N1. And a PCR test is the most important test that we do for diagnosing these. So how do we take it? Throat swabs are taken, nasopharyngeal swabs are taken. If the patient is intubated, then we do tracheal aspirates. Those are typical chest X-ray findings in these patients. Do they differ when the mother is a pregnant lady? Not really, because these are the typical ones that we see in each and every patient. So these are non-homogeneous opacifications which are seen as fluffy shadows all over the lungs. And if you get a CT scan done, these are how badly the destroyed areas will look like in all these angles. There is an acute respiratory distress syndrome definition by Berlin criteria, which tells whether the patient is in ARDS or not. I'm not going into the details of these things because this is not relevant right now. But this is what we normally follow as intensive care physicians. So coming to women who are pregnant, whether they are at risk and what happens to them. Pregnancy, is it a risk? Pregnancy may not predispose them to an increased risk of infections. But what we all need to know is, whenever a pregnant lady is exposed to H1N1, the risk of morbidity and mortality are significantly higher. And why does this happen? Because there are a lot of changes in their immune system mechanism in order to accommodate for the developing fetus. So because of this altered immunity, the patient or the mother usually overreacts or underreacts to this particular infection. So that determines the outcome of these patients. Do we have substantial data to support our talk? Of course we do, because CDC has clearly laid down guidelines. This is a paper that came out in 2009 which explained H1N1 and pregnant women. A lot of these articles do mention about H1N1 and their influence on pregnant women. And the current evidence and policies, etc., are very clearly there. So whenever we talk of H1N1 infection, there are three categories that we need to look at. Category A, B and C, depending upon the severity of these presentations. Category A is seen when the patient has got mild fever, a mild cough or sore throat with or without any body ache, diarrhea or vomiting. It is not usually at a high risk for severe disease, and if the patient is not, or if the person is not a pregnant patient, then we don't need to routinely do testings. They should be monitored, reassessed, they should be confined at home, they should not be allowed to mix with people, and antiviral therapy is usually not indicated. So whenever we fill up a form for testing these patients for H1N1, we usually send off category A, B or C. So this comes under category A. Category B is when you have all the symptoms of category A, they are in the high risk groups, and here is where pregnant women fall into this category. So younger age and older age groups like less than 5 and more than 65 usually come under category B. Those having comorbid conditions also come under category B. Immunosuppressed patients come under category B because they are very much at a high risk. Though testing is usually not recommended, we should start antiviral therapy. And patients should be confined as usual to their homes. That is category B. Category C are the extreme ends where we commonly encounter them in the intensive care unit. That's a combination of A and B plus all of these possibilities. Chest pain, breathlessness, drowsiness, cyanosis, etc. So here testing becomes very mandatory and they should be admitted to the ICU, and antiviral therapy has to be initiated at the earliest. What happens to pregnant women when they get this infection? Spontaneous abortions and preterm births become very common. And for the kid, we see a lot of neural tube defects. We see seizures as a common complication. Newborn encephalopathy is very common, and cerebral palsy and death also is a possibility. But whatever it is, these infections cause respiratory failure and refractory shock, which can cascade down a lot of problems within the mother, which can be transmitted down to the baby as well. There are a lot of articles. If you pull up articles of H1N1 in pregnancy, you can get a lot of these things. There is one Indian study which shows 32 cases of H1N1 influenza in pregnancy, and Lancet has produced a very good review article on these. So that is to summarize the seasonal influenza. So this is one slide that I picked up from infectious disease, where it says the influenza, I don't know if this is working, the influenza usually affects on the acquired immunity in the host. So what happens there? Vaccination can help, secondary response and primary response become important. Because of the mutations, patients do not get lifelong immunity. This is something we always need to remember. So if a patient gets affected, there is every chance that they can get affected the next year also. Antenatally, what are we supposed to do in these patients who get into this infection? Confine them to a single room preferably. Infection control policies have to be strictly adhered to. Patients have to wear face masks so that droplet infections, aerosols can be prevented. Standard precautions for patient care like cap, mask, gown and gloves have to be used. Diagnostic testing has to be taken care by according to the categories that we deal with. Empirical antiviral therapy has to be initiated immediately. And when the patient is in the process of labor, intrapartum, what are we supposed to do? We have to protect the infant from exposure to the secretions during or immediately after birth. Mother should use a face mask throughout labor, which becomes important. Adhere to the current infection control guidelines. During delivery, all the persons, as I mentioned, should be having standard personal protection equipment, face mask, gown, gloves, etc. And immediately we need to separate the newborn to an open warmer, which is far away, around 6 feet distance. Both infant, you have to bath the infant as soon as the temperature becomes stable. Postnatally, what are we supposed to do? We need to keep them separate until the mother has had antiviral therapy for more than 48 hours. That's the recommendation. And if the mother has got 24 hours without fever, then definitely yes. And if the cough and secretions reduce, you can definitely get the mother to the baby. What about breastfeeding? Breastfeeding should be encouraged to begin within 1 hour, but whatever you do, make sure that the mother is protected, the baby is also protected from the fomites. And infants who are not breastfed are more vulnerable to infections, so breastfeeding becomes very important with all precautions due to the patient. So how is the newborn taken care of? We need to make sure hand washing practices are strictly adhered to. We need to make sure that you do not spread these infections anywhere, and bonding with the mother becomes very important with all precautions. What is the treatment for this? We need to keep the mother and the baby in a single isolation room, and standard operating procedures has to be a part of each and every hospital practice. We need to wear all of these as personal protection. We need to restrict the number of visitors visiting the facility. Medications have to be duly given to these patients, and biomedical waste disposal becomes extremely important because these are the areas where spread becomes very common. Tablets wise, Tamiflu is the recommended one, which is a FDA category C drug. It can be used for prophylaxis as well as treatment. The dose is 75 milligrams twice a day for 5 days in adults. It is safe in pregnancy in all the trimesters. A negative laboratory test should not stop them from giving these medication. What about the supportive therapy? Patients have to be administered lots of fluids because they are in a very dehydrated state. Oxygenation, ventilator whenever required. Paracetamol definitely is the drug of choice because they are always having high temperatures. Role of salicylates, aspirin is not to be used. Antibiotics have no role in H1N1 infection unless the patient has got secondary bacterial infections. And we all have to remember that we need to keep the patient cool because high temperatures usually have adverse outcomes. And we need to make sure that the patient eats well, drinks adequately. If you pull up this use of NIV is non-invasive ventilation or the BiPAP in H1N1 patients, you get almost 43,000 hits because this is the standard modality of treatment that we use in all the ICUs. Whenever the patient comes with H1N1, if the patient is hypoxemic or type 1 respiratory failure, if they are not doing well on the mask, we put them on BiPAP. So that is the first role. Invasive ventilation becomes important. All of these are the modalities of treatment. I'll just run through because okay, coming to vaccination, the last part. FDA has approved H1N1 monovalent vaccine. There are two types, one is an IM one and there is an intranasal one. IM is what is advised in pregnant women because intranasal one is not very effective for these patients. Intranasal is a live vaccine, whereas an IM one is an inactivated vaccine. So that is the reason why you have to give inactivated one for the mother. Okay. So how many vaccines do we need to give the pregnant woman? Just one dose of monovalent vaccine during pregnancy. If the mother has delivered before you vaccinate them, do you still go ahead and give them? You still do it because you need to protect the baby and you need to protect her from the infection as well. So these are the recommendations that is given by CDC. Possible side effects, very minimal side effects. Rarely GBS can occur. So these are the safety precautions, and this is just a flow chart as to what to do when the patient has got a flu, whether it's H1N1 or not H1N1. Precautions, avoid going to crowded areas, protect yourself, hand washing, do not shake hands, hug or kiss, etc. Ensure adequate sleep, nutritious food, be physically active. Fight the flu with these 3 C's, cover yourself, clean your hands, contain the germs, avoid going in crowded places. Any take home message, this is how you prevent swine flu, the same thing that I just mentioned to you. Thank you.